Cardiac output, or CO, is the volume of blood pumped out by each ventricle in the course of 1 minute. It is the product of heart rate and stroke volume, or if we show that as equations, cardiac output is the product of heart rate and stroke volume. Stroke volume itself is the volume of blood pumped out by one ventricle with each individual beat. Stroke volume generally correlates with the force of contraction. Cardiac output would increase with an increase in either stroke volume or heart rate, or both. In times of need, cardiac output can be increased by about 4 to 5 times higher than normal, or in trained athletes, 6 to 7 times higher than normal. Stroke volume itself is calculated by finding the difference between the volume at the end of diastole, or the end diastolic volume, and the volume at the end of systole, or the end systolic volume. If we showed that in our equation, stroke volume is the difference between end diastolic volume and end systolic volume. Stroke volume can be altered by adjusting either the end diastolic volume or the end systolic volume by changing preload, contractility, or afterload. Preload is the stretch on cardiac muscles just before they contract. Cardiac muscles, as they stretch, tend to cause a harder kind of contraction. So what we're looking at here is really the volume of blood in the chambers at the end of diastole, the end diastolic volume. As end diastolic volume increases, it should increase preload. So normally anything that increases end diastolic volume will increase preload and thus increase stroke volume. A good example is venous return. Venous return can be increased by lengthening the filling time, or the amount of time a chamber can be filled with blood, or by the increased contractions during exercise. Exercise can increase venous return because the sympathetic response of increased blood pressure and increased pressure from skeletal muscle forces extra blood through the veins faster and can cause increased venous return. Either way, whether we have increased filling time or increased blood coming back because of exercise, more blood in the ventricle means the end diastolic pressure will be higher. That stretches out the cardiac muscles a little bit more and increases the force of contraction. Contractility is the strength of a muscle contraction at a given length of muscle. That means that contractility is independent of muscle stretch or of end diastolic volume. An increase in contractility can be caused by an increase in calcium leaking into the cardiac muscle cells. That can be stimulated by the binding of epinephrine or norepinephrine during sympathetic responses. The flip side is that contractility can be decreased by taking medications such as calcium channel blockers. If we decrease the leakage of calcium into the cardiac muscles won't contract as hard. Afterload is the pressure the ventricles must overcome in order to be able to eject blood out of the chamber. We can think of it as the back pressure of blood pressing against the semilunar valves from the aorta and the pulmonary trunk. In healthy people, afterload is relatively constant. However, with conditions like hypertension, it reduces the ability of the ventricles to eject blood. Hypertension tells us there's more pressure in the blood vessels pressing back against the semilunar valves, so the heart would have to contract with more force in order to overcome that increased pressure. If the heart doesn't contract with more force, it means that it's going to eject less blood with each beat. If we look at these different variables and how they affect cardiac output, preload is the amount of blood that travels down from the atria and starts to fill the ventricles, pressing out against the walls of the ventricles, causing stretch. The more they stretch, the harder the contraction will be. Contractility is independent of that because contractility can be increased by things like sympathetic signals that cause an increase of calcium diffusing into the cells and causes a much harder contraction. An afterload is represented as the blood pressing back against the semilunar valves, the blood pressure within the pulmonary trunk and the aorta. In order to push blood out of the ventricle, we have to contract with enough force to overcome that afterload. So as afterload increases, either the contraction of the heart has to increase by contractility or preload, or the volume of blood being ejected will get reduced.